What are the clinical features and management of acute anaphylaxis? So what it's very easy to remember. Whatever is produced, think about blocking that. Histamines are produced, prostaglandins are produced, cytokines are produced, and they are causing certain functions like vasodilatation, bronchoconstriction. Think about what can reverse it. So that's why epinephrine was given, the chlorpheniramine was given to block it, and the next thing, how may such sensitivities may be detected, and what can be done to desensitize the patient. For prevention, how can you find if in a population somebody is allergic, how can you identify him? How can you test him? And then if he is or she is allergic, how to protect them? Okay? Let's see how we can identify them and how then later we can protect them. So this is the process of identifying them. Now, certain other facts about IgE, mast cells and basophils. Mast cells are in the tissues. Can you measure them? No. IgE normally are at very low level, nanograms in the blood. Even though you can measure total IgE or specific IgEs, but they are not very informative. So what to do to find out how you will diagnose the case? How will you? If you do CBC, for example, if you find high eosinophils level, do you think it will tell you details about the allergy? No. So eosinophils cannot tell you, mast cells cannot be detected, IgE levels are very low. Yes. So you will perform skin test, and the first example, this immediate reaction, to detect immediate reaction, we call it skin prick test. Okay? You just prick the allergen into the skin, leave it for a while. How much long? 15 to 60 minutes, and then you will find the wheal formation. Why? Because the mast cells are in the tissues. If they are already sensitized, they are just waiting for the allergen. When you will inject the allergen, it will bind, cross-link this mast cell, degranulate, histamine will come out, and it will create all the features of allergy. So what will happen? Within 15 to 60 minutes, the wheal formation take place. And you know now this is caused by allergen or IgE. Also, the same patient, if he is observed for another 12 hours, the late phase reactants, the cytokines and the lipid mediators, prostaglandins and leukotrienes, they can also cause the influx of Th2 cells. These Th2 cells will come here as well. So this second figure is also actually about the skin prick test, but just telling you that after 4 to 12 hours, you will also find not just the raised skin, but also Th2 cells. The third test, this one, it is actually in advance. We have not yet discussed the delayed type hypersensitivity, but because you all know that tuberculin test is a recall test to find out past or latent infections. It cannot tell you about the active infections. What you should do for the active infections? Sorry? Yes, you can culture first the pathogen, or you can do the interferon gamma release assay. PCR? Yes. Please we agree on something. So PCR and interferon gamma release assay, both of them can be performed. So here, what is the difference between skin prick test and tuberculin test? The tuberculin test also has got certain, you can inject the antigen, but it will go deep. It will not be in the epidermis, it will go into the dermis. And when it goes in the dermis, after 12 to 48 hours, there will be influx of cells, but which cells? Th1. So delayed type hypersensitivity is different from skin prick test, which is performed for the immediate hypersensitivity. Here, Th2 cells at 4 to 12 hours. Initially, there is wheal formation, while delayed type hypersensitivity will take place 12 to 48 hours with Th1 cells. This one, eczematous patch test, just ignore this. It's not for you. And this is how it looks. So this is the wheel formation which has got well-defined edges, just a raised part because of the allergen, type 1 hypersensitivity. While this one, what is this? It is actually to show what is erythema. Whenever the blood flow to a tissue is increased, it will look just red red color. It's actually, I wanted to just show you that atopic dermatitis of type 1, the patients, the little kids who have got allergies of the skin around elbows or knees, they will have like this erythematous scaling of the skin. Now, let's look at the treatment. So far I have told you, immediate hypersensitivity, it's very quick. It is caused by IgE antibodies. The whole mechanism is Th2 activation, class switching to IgE, coating of the mast cells, which is called as sensitization. In first exposure, there will be no symptoms, but on repeated exposure or subsequent exposure, the patient will have symptoms because of the mast cell degranulation, histamine, lipid mediators, and cytokines. Are there patients who will not be, triggered by this whole process and still have features of allergy? Is it possible?
No.
Yes, non-atopic type 1 hypersensitivity. And what are the causes of that? Exercise, contrast media, vancomycin, opiates. These all, and complements, C3A, C5A. Once it's triggered, how can you identify such patients? You can identify by skin prick test. And it will be evident after the prick 15 to 60 minutes later. And it can also show you the late phase, which is after 12 hours, and Th2 cells will come there. And how it is different from the tuberculin test? What is the difference? First thing is that immediately after 15 to 30 minutes, do you see something? No. That is one difference, that immediate hypersensitivity is after 15 to 30 minutes. But delayed type tuberculin reaction, you see nothing until 48 hours. So the time difference is big. That's why one is called as immediate, the other one is called as delayed. Now, the next thing is that, anaphylaxis we discussed also in detail, that the severest form of type 1 hypersensitivity is anaphylaxis, the moderate form is bronchial asthma. But they have the same activation, sensitization, and release of mediators. But one is severe because maybe the allergen quantity is too much and it will result in bronchoconstriction, vasodilation, increased permeability, hypovolemia, unconsciousness of the patient, and you can reverse it by epinephrine or anti-allergens. But as a whole, if you are treating a patient of allergy, what are the possible things that you can do? First thing is, if you tell the patient, avoid allergen. The allergen, if he or she knows that he is allergic to food, or pollens, or dust mite, or cat, or dander. So first thing is, or penicillin, yes, tell them to avoid it. That's the first thing. Next thing is, IgE is the main thing responsible for causing this disease. So you can introduce antibodies in the body that will counter them, that will block them. Okay? So monoclonal anti-IgE antibodies. And they are of two types. So let's say this is the antibody against the allergen. You can block it by monoclonal antibodies against this part or against this part. What is the difference? This will protect sensitization. This will protect allergen binding to the mast cell potent antibody. So this is to prevent sensitization. And this one is to block mast cell degranulation. So this one is for protecting the sensitization. This monoclonal antibody is for protecting the mast cell degranulation. Then another thing is there are certain drugs which can neutralize the histamine, anti-allergy. One example is chlorpheniramine that we saw. And another, some medicines can stop the mast cells from releasing histamine. They are called as mast cell stabilizers. They will just keep the mast cells intact, will not allow it to release it outside. And by any of these measures, you can prevent allergic rhinitis, urticaria, which is skin allergy, food allergy, or bronchial asthma. So this is just to tell you what are the possible things you might use. So you can use to avoid allergen, then monoclonal antibodies against the FC portion or against the antigen binding fragment. You can block the histamine and you can stop the release of histamine, and this all will help in treating such patients. Any confusion so far? First one. A patient comes to me, he says that I have allergy to pollens. Okay? I will ask him to wear the mask. What will it do? It will try and prevent the entry of pollens into his system. If somebody is allergic to nickel, you can tell him, please don't wear nickel watches, avoid it. Somebody is allergic to peanuts, don't eat peanuts, cereals. You will be, people are allergic to milk, proteins. So first, you have to take a very good history. They have cats at home, they can be allergic to cats. So take out the cats. If you have a lot of carpets in home and it aggravates your asthma, don't use carpets, just use tiles. So avoid the allergy. Okay. Anything else? 5. This one? 5. Okay. All these measures are going to prevent all these things. So a patient of allergic rhinitis can be treated with anti-allergy. A patient of urticaria, skin allergy, they can be treated with antihistamine. Food allergens, you avoid it. So basically it's collectively shown that all these things can be protected by these measures. Okay. Anything else? 4. Then, we have talked about that sensitization, mast cells will be activated. Finally, they will release histamine. So actual thing that is going to cause the allergy symptoms, it's histamine, lipid mediators, and cytokines. So you should think about blocking them, but histamine is on the top. It's the first one that is released. So give them antihistamine or stop the release of histamine coming out. Anything else?
But for example, someone is allergic to penicillin. Why is he allergic and I'm not allergic? Why he has sensitization? I'm not.
Yeah, that's a very good question to which I don't have the answer, because most of the doctors don't have the answer. Why some people get diabetes, why some people get blood pressure, or why some people are allergic, I don't know. It's there are hypotheses that maybe MHC, the class 1 and class 2 structures, they might be responsible. Genes are responsible. Environmental factors are there. Like for example, for asthma, there is one very strong hypothesis. I don't know how strong it is because it's yet to be established. It is called as hygiene hypothesis. What is that? You have seen that the incidence of allergy and asthma, it has increased a lot in the developed countries. So America, Canada, Europe, their allergy and asthma rate is too high. And the poor countries, Bangladesh, or where there are a lot of, there is poverty, hygiene is not very good, they are all the time exposed to these things. You won't find people being, allergic to these things. So they say that when you are too much in hygienic conditions, you are prone to develop these diseases. But when you are exposed to all this, it's fine. So I don't, this is called as hygiene hypothesis. Number one, somebody is allergic to carpets. They say that whenever somebody is brushing off the carpet, the simple dusts get up in the air and it aggravates their asthma. So we tell them, don't use carpets in the home. Okay? Or sometimes, people don't clean their bed sheets very much. So 10 days, 15 days, there is dust. Better to get them clean frequently, wash them. Avoid allergies. Cats, don't eat cats, pets, dogs, don't eat cat dogs. All these things, so when you take the history of an allergic patient, you have to ask their food habits, their living habits, their environment in the home, and then you tell them, these things you do. In one of the Hajj, I encountered an asthma patient. He was a chronic asthma patient, and we were waiting in Arafat. And he couldn't breathe. And just somebody told me that he was asking. I said, sitting just down and inhaling all the fumes. Why when his mask was down, he said, I cannot breathe. You should put your mask. Entry of all the fumes and dust, all the bad things can activate your lungs. Then possibility of outside. But if you are taking more and more histamine release, more problem. First step is avoid it. Give them more antibodies to bind this size or to bind this. Number 2 is this. Number 1 is this part and 1 is this part. Okay. Now I'm going to just tell you a little more detail about another new thing which is called as desensitization or hypersensitization. What we do is, the question here is, what higher doses of allergen can do? What is your response to this? Look, there is a difference between, one is minute quantity which can cause the allergy and the patient get exposed to that again and again. Okay? That is simple allergic response. He will keep having the allergy again and again. But this is therapeutic to treat the patient. You give him low quantities in the blood, then little more, gradually increase the dose for months, sometimes up till 2 years. What it will do, it do a very significant thing. It start producing IL-10. And what this IL-10 is going to do, it will stop the class switching of IgE to IgG4. So you know that Th2 cells, they can produce IgE, but they can also produce IgG4. But they have to be switched. So when the allergen quantity is increased, IL-10 play the role. It will stop IgE class switching to IgG4. Now, when IgG4 is produced, what do you expect? What's going to happen? Why?
Because there is no IG.
That's a good answer. So let's say these are mast cells. These are Fc receptor. IgE bound to it. With the allergen and mast cell degranulation takes place. This is normal. Not normal, I mean for allergic patients. On the contrary, if now IgG4 is produced against this allergen, this IgG4, it cannot bind to this Fc epsilon R1 because this is special for IgE. This is going to just bind to this allergen. Whenever it finds it in the blood, it will just capture it and opsonize it, and then macrophages will take it up. So it will take up all the extra allergen in the blood. IgE will bind the allergen, macrophages will take it. More allergen, so gradually your blood system will be cleared of allergen. So this class switching, instead of IgE into IgG4, is going to clear your blood of the allergen. And here is the graph. So this is a patient who is receiving injections of the allergens. You see in the start it is more, then the dose is increased but the duration is slightly increased more. What is happening? His symptoms were here much. You can see with this pink line, the symptoms starts to drop gradually. You can see it's from 6 months till 2 years span of a patient, and gradually by the end of 2 years, his symptoms have reduced. You can see decline of IgE. This green line is IgE. IgE levels are dropping, and they have dropped a lot. And IgG4, they are increasing gradually. This red line. And by the end of 2 years, the IgG levels are very high. In fact, 10 times more than the normal. So this particular thing is called as desensitization. Okay, so it's a therapeutic modality, well established, and patients who are too much disturbed, their quality of life is too much disturbed by the allergy, they can have this treatment done. Now we'll go to the delayed type hypersensitivity. Just one is done so far. So delayed type hypersensitivity is type 4. It is mainly concerned with T cells or T cells? T cells. The reaction is slower, that's why it is called as delayed, and it is mainly caused by the T lymphocytes, either by CD4 cells through cytokines or CD8 cells by direct damage. The clinical appearance of the reaction is delayed. It takes 48 to 72 hours. Sometimes it can take even more. There are 3 variants of it. One is called as contact hypersensitivity, the picture I showed you in the beginning. So the patient, when come in contact with poison ivy plant, they develop contact hypersensitivity. Number 2 is called as tuberculin test, which is done for TB patients. Number 3 is granulomatous hypersensitivity. Again, this is seen in TB patients. These two takes 48 to 72 hours, while this one takes around 21 to 28 days. This is how poison ivy contact dermatitis looks. This is the local induration seen in tuberculin test. Okay, so there is redness and some raised area. While this one is hardening of the skin, just to show you that granuloma can also apparently look like thick hard skin, but actually it's going to take place inside the lungs. Now, what are the details of contact hypersensitivity? It has again got 2 phases, like type 1. First is called as sensitization. What is happening in sensitization? The hapten of poison ivy, it will be absorbed in the epidermis. Okay, so this color is epidermis, this part is dermis, and this is basically the regional lymph node. So, do you still remember what was hapten?
Yes.
Hapten are the small molecules which by themselves cannot trigger the immune response. They need to bind to a carrier protein. In this case, the carrier protein, where is it? It will be inside the cytoplasm of this dendritic cell. Okay? And there is another place as well. Epidermis has got special cells which are called as keratinocytes. The cell that makes the epidermis of the skin, they are called as keratinocytes. These haptens will either go in the cytoplasm of keratinocytes or in the epidermal, dendritic cell in the epidermis, and the dendritic cell is going to take it to the lymph node, activate CD4 cells, and then activate macrophages, So this is the first phase, activating CD4 cells, activating macrophages by the epidermal dendritic cell. In phase 2, let's say the second time exposure has taken place. Now these keratinocytes, they already have got haptin inside them. Okay, so in the epidermis, they have got haptin inside them. These active CD4 cells, when come here, and CD8 cells also, they will directly cause damage to these keratinocytes. And this is the so imagine the binding between the epidermis and dermis. If it is intact, you won't see any vesicles in the lesions. But any disease that is going to disrupt the structure, all the keratinocytes which are binding to each other strongly, if they are destroyed by the cells, it loosen up, fluid goes in, and that's why in these contact dermatitis you see vesicles, fluid-filled vesicles. The feature that you see is because of the damage to the keratinocytes in the epidermis. Everyone understands this or not?
Yes.
See, in the first phase, dendritic cell is going to activate CD4 and CD8 cell. That's sensitization. Re-exposure, now this haptin, it is not just here, it is also in these keratinocytes. Okay? So CD4 cells, CD8 cells, they come here. What is the job of CD8 cell? It will kill the cell. So when they start killing these keratinocytes, you can see the color has changed. All these keratinocytes are killed and the epidermis become loose. It will be fluid-filled. That's why this picture, this fluid-filled structure, vesicle, this is the result of damage to the keratinocytes directly by CD8 cells. Okay? Now, the details of the signaling are that here you can see the dendritic cell express the antigen to CD8 cell and CD4 cell, and they will produce interferon gamma, IL-2. They will activate the keratinocytes to express MHC class 2 and MHC class 1, and this is the activation phase. Normally what happens, patients, they go, people, they go for climbing or picnic or hiking. These plants are mostly in the West, they are in such areas, and when they are walking, just the contact with the plant will result in vesicles in about 48 hours. So when they come back from hiking, or still if they are on the trip, they've developed these vesicles wherever the plant touched them. That's why it is called as contact hypersensitivity. But after 72 hours, after 4 days, it subsides itself, even if you don't give them any treatment. And what is the reason for that? The reason is because these keratinocytes are also, after 72 hours, when no more contact is there, they are going to produce prostaglandin E. And this prostaglandin E will also be produced by macrophages, which will block the T cells, activated T cells, and the whole situation is going to subside. So I'll just repeat that how to remember this. This is a plant called as poison ivy. Whenever you get in contact with it, within 48 to 72 hours, the patient develops vesicles, fluid-filled vesicles. Now, first question is, why vesicles in this case and in other allergies, the induration, raised area? The reason is because here CD8 cells will kill the keratinocytes. Why they will kill? Because the haptin is inside them, in the epidermis. So the epidermis become loose, fluid-filled, and those are fluid-filled vesicles. But it also subsides later. After 72 hours, the lesions go back. Why they go back? Because they will produce suppression through prostaglandin E and through prostaglandin E of the macrophage. So T cells affect whether CD8 or CD4, they will stop causing the damage to the epidermis. Everyone is clear about it now? The tuberculosis type sensitivity you can see now here, there is no vesicle, there is no fluid fill, just raised area which is slightly red in color. This is normally termed as induration. Now what is the reason for induration? Now you can see here, the epidermis is normal, the antigen is injected in the dermis. Okay? Once it is injected in the dermis, the